I'm your host, Nick Jikomes, and today I'm speaking with Dr. Daniel Karlin. Daniel is a physician. He's board certified in psychiatry, addiction medicine, and clinical informatics, and he is currently the chief medical officer for MindMed, a psychedelic pharmaceutical company pursuing clinical trials with various psychedelics and other psychoactive drugs to treat psychiatric ailments of different kinds. And we talked a lot about psychedelic medicine and medicine generally in this podcast. We talked about psychiatry and the current state of psychiatry, a little bit about its history and how it got to where it is in terms of how it works and the larger sort of healthcare structures it's embedded in. We talked about medical and academic research and the incentives that can bias and motivate people to behave in certain ways when it comes to medical research and training and treating patients. We talked about psychedelics. We talked about psychedelic medicine and how it's different in some ways from traditional psychiatric medications. We talked about what they're doing at MindMed, some of the drugs that they're testing, including forms of LSD that they're investigating for the potential to treat generalized anxiety disorder, a specific enantiomer of MDMA, which they're pursuing for the treatment of autism spectrum disorders, and some of the other things that they're doing. So if you're interested in psychedelics and psychedelic medicine in particular, drug development as it relates to psychedelics, and sort of broader questions around medical education, medical ethics, patient access to medicines, including psychedelics, and things in that general realm, this will be a really interesting conversation for you. I had a lot of fun speaking with Dan, and he had a lot of interesting things to say around not just psychedelics and what he's doing at MindMed in particular, but just psychiatry and medicine generally speaking, especially when it comes to psychiatry and treating mental health. As always, if you enjoy the content I'm producing, please like, share, and subscribe. Be sure to check out the Mind and Matter Substack at mindandmatter.substack.com. You can sign up for a free weekly newsletter that gives you updates about the content I'm producing and what's on the horizon. You can become a paid supporter to help the podcast keep going and keep growing. This episode is supported in part by Athletic Greens. Their main product, AG1, is a comprehensive and convenient daily nutrition product containing 75 vitamins, minerals, and whole food sourced ingredients with less than 1 gram of sugar per serving, no nasty chemicals or artificial anything. It's gluten and dairy free and compatible with paleo, vegan, vegetarian, and ketogenic diets. AG1 is a quick and convenient way to supplement your diet to help ensure your body is getting the nutrients it needs. It comes in powder form, and you can mix it in water and drink it, or you can put it into a smoothie or a shake or something like that. I mix it into water and drink it with the first meal of each day, and it's super convenient. If you go to athleticgreens.com/mindandmatter, Athletic Greens will give you a free 1-year supply of vitamin D and 5 free travel packs with your first purchase. Their vitamin D product comes in tincture form, so you just take 1 drop each day. A large fraction of the population is actually vitamin D deficient, especially in winter months when we get less sun exposure, and vitamin D is super important for the proper function of the immune system and for a variety of other things. And there's even evidence indicating that vitamin D deficiency is correlated with more severe cases of COVID-19 in those who get infected. Every time I go into the doctor each year for a checkup, I'm always told that vitamin D deficiency is very common and I should be supplementing on a daily basis. So visit athleticgreens.com/mindandmatter or click the link in the episode description. You'll get a free 1-year supply of vitamin D with your first purchase. Hey everyone, I want to take a minute to tell you about a product I use called Everyday Dose. They have created excellent coffee and matcha products with functional mushrooms and other supplements and less caffeine than traditional coffee or matcha products. I actually reached out to them because I've been using their product for about a year or so, and listeners often ask me about my daily and weekly diet habits. They make a really good mushroom-based coffee alternative. It contains micronutrients with antioxidant and anti-inflammatory properties, as well as collagen protein to help support healthier skin, nails, hair, and joints, and the amino acid L-theanine from tea leaves. Each cup has just about 39 milligrams of caffeine. That helps eliminate the caffeine crash that can come if you drink regular coffee, which has much higher caffeine levels. And they use a unique cold extraction process that results in lower acidity than normal coffee. And the caffeine microdose makes it suitable even for someone who doesn't normally drink coffee. This mushroom-based product is made using a double extraction from 100% mushroom fruiting bodies like lion's mane and chaga to maximize the extraction of micronutrients like beta-glucans, triterpenes, and sterols. Other brands don't typically do this, making Everyday Dose one of the highest quality products of its kind. It's gluten, dairy, and nut-free. There's no added sugar. It's paleo and keto-friendly and made with kosher ingredients. There are no grains or fillers, and it is lab-tested to ensure quality. I really like the taste of Everyday Dose compared to black coffee and other mushroom coffees. And they have a mushroom matcha product loaded with functional mushrooms and collagen proteins. So if you like green tea matcha, you'll probably like that product too. If you're interested in a healthy coffee alternative, I highly recommend giving Everyday Dose a try. Check out the link in the episode description or visit everydaydose.com to learn more. If you go there, you can find special offers that they have for getting a free frother and free travel pack of on-the-go doses with your purchase. And with that, here's my conversation with Dr. Daniel Karlin. Can you just tell me a little bit about yourself? Why don't we start with like your scientific background, medical background, before we get into what you're doing today?
Yeah, absolutely. So Dan Karlin, I'm a psychiatrist by profession and by training. I'm also board certified in addictions and clinical informatics, a triple boarded physician. I did my informatics training before medical school, which was a little unusual. So I went and got a master's in clinical informatics and cognition and medicine, which caused me to engage with my medical training probably a little bit differently. One of the things that I'd studied in my very earliest research was how we teach medicine and how we practice medicine and how we think about medicine as we do it. So it set me in what would have probably been a somewhat critical viewpoint of my, or at least a skeptical viewpoint of a lot of what we were learning and how we were taught it. And I think that has carried through my career to date, that I try to be very cognizant of things that we know versus things that are just the way we've done things historically versus things that we maybe think we know, but don't necessarily know super reliably. And trying to categorize our knowledge and the information we encounter in the world in that way has been as much of a theme through my career as anything. I trained at Tufts for residency for psychiatry. I went to undergrad and graduate school at Columbia here in New York, and went to medical school at University of Colorado. So have been all over the country along the path to where I am now.
Yeah. I mean, it's really interesting when you think about science, but especially medicine. Like, obviously it relies on science, and our knowledge is being updated all the time, and it's, an explicitly science and knowledge driven profession, but it also relies on tradition necessarily, right? Like you have to have ways that you do things just so that you can operate a medical practice, and because we don't know everything, right? You have to be able to act even in the absence of knowing every single thing that might be wrong with someone, or why, or what to do about it. So there's this interesting, sort of dynamic tension between sort of the science and knowledge side and the tradition side, just doing things because that's the way that they've been done. Thinking about medical education, I'm curious, like, what were you skeptical about, or like, how does medical education work today, and what are the ways that maybe it's deficient, or the things that's maybe not focusing on?
Yeah, excellent question. And I absolutely will second your point that so much of medicine and the systems in which medicine is practiced, so the healthcare system, but also even our political economic system, everything sort of exists in these these layers of systems, many of the components of which are either political or non-scientific or not studied in a rigorous way. So it's interesting to think in healthcare about layers that are studied, so-called evidence-based medicine, and we can talk about what that means and maybe what it doesn't mean as well, while that sits inside of, say, a non-evidence-based but profit-generating payer system that may modify the way that the actual medicine is practiced. Specifically on medical education, I do think that there are some. So one specific example would be that the way that medical students and resident physicians are trained to think about diagnosis is this interesting process called differential diagnosis, where we give them a bit of information and have them think about all the things that could contribute to knowing this one thing about a patient. And then as we give them more bits of information about the case, they narrow the differential until they're left with a few possible options. And then the question is, well, what would you do to narrow the options further so you might know which direction to go? And while it's appealing to imagine that that's what's actually happening in clinical practice, what we know from essentially the study of cognition and medicine is that's almost never what's happening. That when a clinician walks into a room, they very quickly picked a leading hypothesis for what they're seeing, and they ask questions to confirm and we hope to refute that hypothesis, because it's very easy to just ask questions that go down the road of confirming the thing I thought from the beginning. And so that's the difference between forward chain diagnostic logic and reverse chain diagnostic logic. We teach it one way, even as those folks who've studied it know that the reality is that what's happening in the room is very different. And you can find lots of examples like that in medical and resident education. I think another disservice that we do to medical students and residents is not teach them enough about the system in which they'll be providing care subsequently. The things that they'll be asked to do to make money, to make a profession out of all the information they're gathering along the way. So those are two somewhat isolated examples, but you can find things like that almost everywhere you look.
Yeah, I think there's an analogy with basic scientific research, in the sense that, you're trained to do the thing, but you just have to learn by doing what kind of system you're embedded in, what kind of structure you're embedded in. That, like when you learn to do scientific research, you really more or less just learn the scientific research part. And along the way, you learn to write grants and these things, but you don't really know until you become, a PI somewhere, exactly what you're dealing with in terms of, running a lab from an administrative and financial standpoint, from, what it takes to get grants, and the kind of pressure that will put on you, and the amount of motivated reasoning and confirmation bias this will naturally give you. And, it sounds like it's similar in medicine. So there's not such an explicit focus on the education side to teach, who will become physicians, what it's going to be like to work in a particular type of environment, especially one that's it's ultimately profit driven, is gonna naturally pull your thinking in a certain direction.
Yeah, and even if not profit driven, at least has to get by, right? Has to make more money than it spends to provide care. And I think what the maybe zoomed out version of all of this is, what are the unwritten rules of the space in which you're operating? What are the untaught aspects of surviving? So if you're purely a provider, a doctor providing patient care, patient care is the economy, is the currency of what you do. And it's, are you seeing enough patients? Are you billing enough, high enough billing codes to make your practice profitable? On the far other end is, if you're doing research, the currency is papers, and papers get you grants, and grants get you more grants. And a lot of folks, of course, live somewhere in the middle, where they have a academic medical practice, and they see patients with some of their time, and have to seek funding for research with other parts of their time. Certainly in both, there can be strong, and this relates back to what I was saying before about how we teach diagnostic logic, there can be strong incentive for confirmation bias. So this ties back to one of my core interests, which is measurement. How do we measure things in science and medicine? But I often talk about the fact that we report financial conflicts of interest as these bad things that you should be suspicious of me when I tell you that I get paid to do this, that, or the other thing. But then to report things like papers written and grants funded about an idea, we ought to be equally, if not more, suspicious of the things that I've built, the ideas that I've built a career on that enable me to continue to get funding. So those are the things I'm most likely to go out and not refute, because if I start refuting my own ideas, how am I going to get funding to keep doing research?
Yeah, no, I think that's super important. I definitely, when I was in the academic world, like for my PhD, you could see that very clearly. Like you're in a lab, there's people running various labs. All of those labs, right? They need money to fund all of the research. You have to write a grant where you basically say, here's my idea. Here's why it's relevant and important to human medicine or whatever. And I think this is the way it's going to work. You're very motivated to prove something like that is true. And once that wheel starts turning, right, you want to keep it turning. And so there's just, there's nothing, it's not like anyone is doing anything wrong. It's just that you're organically going to be motivated to go down certain paths and not, disconfirm your original ideas, because there's always going to be this lingering risk that might shut off what what keeps everything going.
Yeah, I think, well, we can obviously find examples of just flat out malfeasance in science and medicine. Of course, there are people who are dishonest or bad actors for whatever reason, but those are almost less interesting to me. They're great. There are folks out there who are actively working to find that and to root it out and to prevent it. And there's malfeasance everywhere, so that less interesting. But I think exactly what you say, which is that people respond to incentives in their environment. Mm-hmm. And often it's hard to identify the incentives if you trust that the metastructure that someone presents the things that they're finding is the outside edge of analysis, right? So if you just look at findings in isolation from an individual research study, fine, you may believe that you've learned something true about the world. But if you shift that metastructure out, open the aperture, as it were, you start to identify these incentives. Like, yeah, well, of course, you're incentivized to continue to find that your previous findings are generalizable and replicatable and all these things. Yet so often when replication research, which is relatively hard to get funded, right? You're not saying, I'm going to go find something new about the world. You're saying, I'm going to test to see if something we already believe to be true is actually true. And of course, in all of science, and psychology has particularly suffered from this lately, there's this crisis of replication where other groups seeking to identify, essentially replicate same or similar experiments end up with very different findings, which usually suggests that something about the metastructure of the original research was set up in such a way that that's what generated the finding, rather than it being a generalizable finding about a larger population or applicable to other sites or other regions or whatever it might be.
Yeah, I remember learning when I was in graduate school. A replicable finding is across fields and across subfields is actually that when some result comes out, we find that there something is true, we think about the world. As that result gets replicated, the effect size tends to go down over time, which sort of points to what I think what we're talking about here, is because people are incentivized to find these sort of big, dramatic, sexy results. And even when they do replicate, they tend to very often turn out to be not quite as striking as originally thought, as people do the same or sort of adjacent experiments over and over again.
I think that's exactly right. And it can be something as simple as how much of social psychology or psychology research is done on college campuses, where the recruitment population is college students at that particular university, and you recruit 40 or 50 or however, and randomize them and then run whatever the experiment is, find some finding and say, okay, well, this is true about people in general, but the selection bias happened way upstream of the research itself. The inclusion-exclusion criteria could be very robust, but if the population from which you're picking is just psychology students at an particular undergraduate campus, that this is exactly an example of, within that narrowly defined metastructure, this may be a true finding, but the generalizability is hampered just because of the population from which that sample was selected.
And when you think about some of these things, how the structure in which we do things can bias us, and when you think about things like medical education, how do you think these things have affected the field of psychiatry generally, especially in terms of how we think about treating things? So treating symptoms rather than treating causes, and putting people on medications that will be revenue generating over and over and over again over many years, and things like that. Because some of the stuff we'll get into is sort of, where is psychiatry today, and where did it come from, and where is it going? But what are some of the, I guess, what would you say some of the major problems are today in terms of how effective our psychiatric treatments are or aren't, and where does that come from, and how do you think about
it? Excellent question, and right up my alley in terms of what I spend a lot of time thinking about when I'm not working on the core aspects of drug and device development. Psychiatry has allowed itself, I think, and contributed to itself becoming less than it could be. And it's done that in the service of this sort of neuroscientification of psychiatry. But the reality is that neuroscience and psychiatry are still living very far from one another, and that's okay. And we need to be making efforts to bring the two together, but recognizing in the interim that fundamentally the practice of clinical psychiatry largely deals with signs and symptoms, right? The phenomenology of disease and things like the DSM. While we need standardized ways of defining disorders or diseases in psychiatry, rough-hewn combinations of signs and symptoms just aren't going to do the trick, and they don't really bring us toward a set of disease definitions that will have biological meaningfulness. And so you look at things like GAD and MDD, right, which we would think of as being pretty different diagnoses, right? One's an anxiety disorder, the other is a mood disorder, an affective illness. Yet the construct overlap between the disease definitions for GAD and MDD in the DSM is 80%. So that means that in theory, 80% of folks diagnosed with one also could be diagnosed with the other. And we see that they're co-diagnosed often. So we've got, and there are a few factors here. So this is going to take a minute of some history of psychiatry. But so fundamentally, we have a biologically imprecise set of disease definitions against which drugs have been tested and in some cases have been demonstrated to work enough to be approved by regulatory bodies and then are prescribed for these conditions. But unsurprisingly, what we repeatedly see is that drugs that have very narrow and precise mechanisms of action are not shown to work because, of course, if you take a group of, say, people with GAD or MDD, acknowledging they have a range of biologically diverse underpinnings of their disorder, and these disorders are, of course, the result of complex interplay between the biology of the person, their in utero and early childhood experiences, their adult experience, their current living environment, the stresses in their life on a day-to-day and year-to-year basis. And so very precise mechanism drugs, well, why would we expect them to work against something that is likely a multitude of fundamentally rare diseases? And drugs that do work against anything often seem to work against a bunch of things. You think about the second generation antipsychotics that started with indication for things like schizophrenia, then wandered into bipolar disorder. And of course, they're now adjunct antidepressants as well. So psychiatry, so taking that, as a starting point, and then we look at, okay, so what's the role of psychiatry been in the world since it's, the start of the 1900s when psychiatry is becoming a thing. And psychiatry initially, think back to Freud and, who's doing the talking cure for neurological illness, curing neurological disease with his voice, and people like Kraepelin, who were doing very fine-grained phenomenology in mental hospitals. And what's happened is that along the path to here, one, when a disease gets more of a biological underpinning, so think epilepsy. Epilepsy used to be treated in mental institutions. It was seen as a psychiatric disorder. As neurology advanced and EEG signals for epilepsy were discovered, it became a neurological illness. Now there's some accidental tails that come along with moving a cluster of diseases into a new specialty, which is that we know that there are what we used to call psychogenic seizures or non-epileptic seizures. Now neurologists have to own non-epileptic seizures, even though those are very likely more psychiatric disorder, some sort of conversion disorder. And so that trend over time has reduced and changed what psychiatry takes care of in interesting ways. Every specialty has diagnoses that the specialists in that field, like functional abdominal pain, acknowledge are a complex interaction between brain and body, which most diseases probably are, that maybe would better be treated by addressing someone's stressors and their mood and their anxieties. But and this gets into a whole nother line of reasoning, which is defense mechanisms and how we defend against uncomfortable feelings. Certainly some people defend against uncomfortable feelings by experiencing them somewhere in their body. So then when you confront that defense by saying, well, maybe you should go see the psychiatrist, like, oh, are you telling me this is all in my head? And that's the defense doubling down on itself by saying, well, if you don't accept this is in my body, I'll just see someone else, right? Because when you confront a defense directly like that, it pushes back strongly to protect itself and its protective function for the person. So psychiatry moves forward through time, And in the modern payer environment, we've disposed of our most precise and at times curative intervention, which was psychotherapy. And really, I'm talking about dynamic or depth psychotherapy. And given that to providers with less training who get paid less because they're expected to be able to make a living on the payment rates from third-party payers for psychotherapy, while psychiatry is very much moved in the direction. This is all, we're talking third-party payer supported. It's a different deal if you can afford to pay some privately, and you can, there are providers who just do that and provide psychotherapy as psychiatrists, or, whatever else. But from a payer perspective, if you're a psychiatrist who's going to take insurance as your primary payment mechanism, be in network and all of this, likely what you're doing is short med management visits, because that generates the sort of salary you were told to expect, based on the training you received and the time you spent getting there. And so psychiatry is more or less relegated itself in the payer environment to prescribing, and psychotherapy has been shifted over to master's level psychotherapists, who some of them are incredibly competent. And in no way do I want to. Sometimes this sounds like it's sort of inter-provider rivalry, but I'm really just trying to describe the reality of the practice environment. And because those folks likely they can go get a lot more training, but in order to practice, they have less training to get out the door. And psychotherapies like cognitive behavioral therapy were meant to be a solution to that. How do you take someone with less training, less experience, and give them something that's more likely to be effective? But of course, cognitive behavioral therapy is not historically what depth psychotherapy was. And it's, it's called evidence-based because it's easier to study. It's easier to show results that look a lot more like drug results, which is symptom reduction at 4 and 8 weeks. But maybe that's not the point of psychotherapy, is symptom reduction at 4 and 8 weeks. Maybe symptoms get worse on the way to getting truly better.
Mm-hmm. And what, one interesting question that comes to mind is how should we think about something like patient autonomy when it comes to thinking about the whole diagnostic and treatment process? Because on the one hand, naturally, naively, intuitively, you want complete patient autonomy, right? You want to have your choice of doctors. You want to be able to choose a doctor you're comfortable with. You want to be able to go to whoever you want. That's definitely my inclination as a potential patient. I think it's everyone's natural inclination. But on the other hand, just like in any other sort of sector we could talk about, when the customer, the patient in this case, has the choice between multiple providers, multiple physicians, the sort of insidious loop that can take hold is, if I don't like the answer that my physician gives me, I can simply go to another one until I get the drug and the prescription I want or the treatment I want. I might not like a diagnosis, even if it's accurate, just because I don't like it. And, I can think of many examples in my own life, and I think this is probably pretty obvious to everyone. A lot of people out there who have some pill they take or some treatment they're getting, they sought it out. They either got it on the first shot with the first physician, or they simply went to someone else when they didn't get what they wanted the first time.
You're touching on something that's incredibly important and societal, even as much as it's medical. And there's so many different angles to look at this from. One is the ethics of medicine, where there are 4 values that can align or can be in competition: beneficence, non-maleficence, justice, and autonomy. And we, in American medicine, tend to privilege autonomy over almost everything. So if you think about end-of-life care decisions, or, as you say, the ability to sort of get the treatment that you think is the right one for you versus the one that the first doctor recommends, and intuitively, autonomy makes just a ton of sense, right? People should have the right to bodily autonomy to choose for themselves. But at the same time, that presupposes that, particularly in psychiatry, that what someone wants for themselves is necessarily what's best for them, so that the beneficence and autonomy can come into tension with one another, or that what someone wants for themselves necessarily represents what's best for everybody as a generalizable concept. So there is autonomy coming into tension with justice. And you can think of examples where what someone wants. So someone goes into an ER and says they have back pain and wants opioids, and that may be harmful to them. So those two values, non-maleficence and autonomy, come into tension. So there are all kinds of examples where what the request for service is doesn't necessarily match what the provider of whoever the patient is seeing thinks is best for them. And so how do you resolve that tension? It's a really tricky thing. And then overlay on that, and an example I like to use is anxiety, depression, so let's say neurotic illness, pain disorders, and addictive disorders. Some people clearly live in one piece of that pie or another, or one part of that Venn diagram, however you want to think of it, or another. But a lot of folks sit on an intersection between either two or all three parts of that. And for example, if you're someone who sits somewhere in the middle of that, you go see a psychiatrist as your first stop, well, they'll take probably an orientation toward how do we deal with your neurotic illness? What are the medicines and the potential psychotherapies we can do for that to make your pain or your addictive drive less relevant and less important to you and less needed. If you go to a pain clinic, they'll start with the pain and give you pain treatments. And if you go to an addiction clinic, they'll start with the addiction and maybe give you a drug to reduce, an opioid partial agonist like Suboxone to make it so you use fewer drugs. And so what a weird thing that the person sitting at the intersection of these likely disturbing and functionally impairing experiences of life is the one picking what the right treatment is. So it's both understandable that we privilege autonomy and really tricky. I mean, another example is informed consent. So we and again, not saying this isn't important, but there are aspects of informed consent, particularly an overemphasis on the risks of an intervention, that increase the likelihood of having that risk. So the nocebo effect is alive and well, right? That you can, if you hit what the bad things about this medicine are going to be too hard, someone's more likely to experience them. You warn someone about sexual dysfunction enough, you can definitely get them to have some sexual dysfunction. And on the other side of that, if a medicine is prescribed with good trust and rapport between the person prescribing it and the person taking it, the medicine's more likely to work well. So there's clear tension with the right and responsibility for a person to know the risks of something they're undertaking medically, but also the risk that they don't sustain enough benefit or that they're even potentially harmed by knowing those things. And I don't think we have good resolution to this or clear answers, but I will offer that there is, a real, at least starting point solution in the dyad between a physician and a patient is to discuss these things. And if there's, of course, now there's the tension with time in the room and billing and all those things, but to start from the perspective of what are your goals for yourself? How can I help you reach those goals? And to make it as much as possible about the person and what they really need versus what their primary request for service is.
One of the things we'll talk about too is sort of the mental health trajectory of the U.S. and the Western world, broadly speaking. I think most of the world, broadly speaking, a lot of things are on the rise. So mental health, by many different measures, has been on decline for quite some time. So, we can cite various statistics to anchor us, but, anxiety and depression, generally up and to the right for most groups, some more than others. Things like ADHD up and to the right, autism. We go down the list. More people are being diagnosed with things. More people are taking not just a psychiatric medication, but often combinations of them, very often chronically for long periods of time. Costs are ballooning, et cetera, et cetera. But just on the piece of sort of our mental health trajectory, how do you start to think about the apparent conundrum of, on the one hand, things are good, right? Like we have more technology and fancier technology than ever. We have more medical and biological knowledge than ever. Our lives are easier by many measures than they were for, our ancestors in the deep past, certainly. They're more comfortable, at least. And yet, people are sadder and more anxious and less able to focus. And there's a million different things we could talk about that tie into this and many different sort of levels where the discussion could sit at. But why are we on this mental health trajectory? And what does that have to do with the way that we conduct Western medicine today?
Well, you certainly acknowledged one part of this, which is maybe we're just detecting this better, and we're giving people permission to be unwell in whatever way they are, and to ask for help, hopefully to ask for help with that, and that help may come in the form of medicines that may help. That's almost, well, interesting from a health systems perspective and a service delivery perspective. I think from a philosophical or even from a true psychological angle is a little less the interesting question, which is, so let's assume that we do, as you say, probably live in about the safest world humans have ever lived in. There's some blips. COVID obviously was not a period of radically increasing safety or anything like that. And wars and things will put us into regressive periods where more people are dying younger. But generally speaking, we probably as safe as it's ever been, and more likely to have access to food and water and things that hundreds of years ago, or even 100, 150 years ago, less likely. Of course, there are places in the world where that's not true. There are places in the country where that's not necessarily true, where there's not access to say clean water in certain places. But why are we so anxious? Why are we so depressed? And there's an angle on that, which you mentioned, access to technology. So for even with folks who have their basic needs met and are able to get food and water and shelter and are generally, you'd think, living in what should be relative comfort versus most of human history, why are we so anxious and so depressed? And I think part of that is that we're constantly confronted with messages of danger and risk. And it's all around us, right? Partly, I think, because that sells, that captures. We're in an attention economy, and have been for a long time in terms of print media, but certainly in video media, starting with TV and progressing through now to sort of everyone being on TV, and someone else too right now, of course. But in order to keep attention, one really effective strategy is to present risk. We're evolutionarily attuned to pay attention to messages of risk, to potential danger. And so being constantly inundated by messages of risk, I think, very likely a component of this. I also think, and again, this is sort of a worldwide phenomenon, but also very present around us here, that economic inequality and being constantly exposed to what the great things that other people have, or you perceive them as having, while at the same time being confronted with extreme poverty, I think leaves a lot of folks who aren't on either end of that striving in a way that they're reaching for something they're unlikely to ever grasp, while at the same time having to look down, literally beneath them on the streets, and see what happens if they don't just keep grinding.
And what about, just talking about abundance itself? I think, it's very easy for people to think, oh, we live in this world of abundance. There's lots of food, there's lots of stuff around, and that's why things, are comfortable, and that's why the modern world is what it is. We have used, our brains to create technology and to create social structures that give us an abundance of stuff, and therefore it's often counterintuitive to think, well, if we have all this abundance, why are we becoming less healthy in many ways? But is it possible that abundance itself is the problem? If we sort of think about that question, and then, in parallel, think about, early hunter-gatherers, the types of people that we evolved from, they had to go out every day, and there was many signals of danger in their environment, right? Like they didn't have billboards and Facebook and social media, but you actually had to go out into the woods or into the savannah, and there were actual monsters that would eat you potentially. And you really had to think about getting food, not because you just want something tasty, but because it was a matter of life and death. And does abundance play a role here, where all of these sort of basic survival things are there, and they may not be equitably distributed. They may not be, where we want them for everyone, but we don't have to go out into the world and move our bodies for literal life and death reasons like our ancestors did. And so that abundance creates space for a lot of other mental health problems to just bubble up, because we aren't focusing our minds on literal life and death, day by day, week by week.
Yeah, it's certainly possible. I mean, this is something where I often wonder what it would be like to engage with phenotypically, genotypically modern humans, as they expanded across the earth. They're crossing the Bering Strait 30,000 years ago, and what that experience was like. Of course, communication would be somewhat difficult, and we'd have a common means of communication. But even just watching social interaction would be incredibly interesting. Where does dissatisfaction come from? It's a hard question, and if we had easy answers to this, we would certainly, we'd probably be better off if there were modifiable factors. Alienation from one another, I think, though, is the sort of last 500 years of human history is probably dominated by increasing alienation from each other and alienation from self, which of course manifests as these defense mechanisms I was talking about earlier, and just the fundamental feelings of unease in the world. When I used to practice addiction medicine. I did addiction clinics in the Boston area. And the best conceptualization that I heard from of the nature of addiction through that was lack of connection, that addiction sort of replaces true human connection. And certainly as we look at what sort of masquerades as human connection today, a lot of it isn't. A lot of it isn't the sort of connection that you'd hope for, and that you could derive satisfaction and comfort from. And certainly, you can have a large count of people on your Facebook, your Instagram, or LinkedIn. I wonder how much of that actually causes the feelings of satisfaction that come from a real sense of connection.
Yeah. I mean, it strikes me that, on the one hand, we live in a hyper-connected world in social terms, but in another sense, it's actually the opposite. So if you think about, our ancestors, the type of human being from which we evolved, that we still are sort of under the hood in many ways. We evolved in bands of dozens, maybe hundreds of people, most of whom you knew and probably knew very well. Family, very close friends. Most of those people were not mere acquaintances. But today, right, it's much more likely that you have many more connections, many more people that you know or know of, but the strength of your connection, the thickness of the line connecting you is much weaker today. And that does seem to be a trend for a lot of people. And so we're in this, I guess, somewhat paradoxical situation where the opportunity for connection is sort of more abundant or easily available. And yet the number of strong connections appears to be going down, I think, for a lot of people, actually, despite that.
Yeah, and maybe even the strength of those strong connections. You think about what ought to be sort of, if you just said, well, automatically, who are your strongest connections with? And, family, either family of birth or a family that you've created through bonds like marriage. And 50% of marriages ending in divorce, and as much interfamilial birth family acrimony as exists. It does seem that even in those places where the strong bonds ought to be identifiable, or where we would point to and say, well, those are the strong bonds, maybe they're not. And I think that both the sensation of those bonds not being as strong, and or the worry that they might go away is a huge source of distress. This relates to narcissism, of course, which is experiencing the self through the reflection of your own projection, our projection, and how it's reflected back. There's a whole interesting thing about character development, personality, that sort of is a through line, I think, from very much what you're describing, the sort of modern evolution of our relationship to one another and to and through technology.
And so when we think about mental health and social connections, and start to try to tie that into like how psychiatry approaches treating things today, oftentimes with medications that are taken chronically, that are sort of just nudging things one way or the other. Like if you think of something like an SSRI, right? They're essentially just elevating serotonin levels, and the hope is that that's going to sort of nudge you in a certain way or another. They have some level of effectiveness that we can talk about. But, now, the subject that you work on and that we'll sort of come to and tie into this is you've got a very different kind of medication being talked about in the mainstream now, which is psychedelics. And they aren't these drugs that have sort of specific and what would you say? They have sort of, an SSRI sort of is a drug that has a sort of broad, weak effect. It's just sort of meant to like kind of nudge you in one direction. Whereas, when you take, LSD or psilocybin at a sufficiently high dose, you're going to have, an hours long experience that you'll remember for the rest of your life. So it's a very different kind of beast in terms of how it works acutely, at least. And so how do you start to think about some of these things, and how does that inform sort of the direction that you've gone in?
Yeah, again, that opens up just so many interesting doors that we could walk through. I'll start with SRIs. I don't include selective in there because, they're not particularly. And so here we have serotonin reuptake inhibitors, right? That we know that they do that. And when they were developed and approved, we said, okay, well, that's the mechanism. We're going to call them SRIs. And they start blocking the reuptake of serotonin after the first dose. And you can see fMRI changes and amygdala hyperreactivity after the first dose. They're doing something right away, but we all now know that they take weeks and sometimes months to get to the right, to get up to a high enough dose that they actually do whatever it is they're doing, which is clearly not reuptake. It's not mediated through the blockade of the reuptake of serotonin. It's mediated through some downstream or other process. So even those, since the very early 90s, the drug that has been prescribed millions and millions of times, don't really know how they work. But what they do is modulate symptoms. And I said this about cognitive behavioral therapy before, that very much of the same sort of modality, which is, can we make the distressing symptoms in your life less distressing? And, I have to be so careful in what I do, MindMed, as we're developing drugs that fundamentally are different than that, or some are, and some are more similar to that, to be careful not to dismiss that these do add real benefit to real people's lives. And there are people whose lives are a lot better because of cognitive behavioral therapy or an SRI that they've taken chronically, and their life is more livable and they're more functional because of it. So I never want to dismiss that out of hand. We got to have a lot of tools to deal with the reality that a lot of people are suffering, and they're suffering differently from different underlying pathologies. But then you look at a drug like MM120, their MindMed's pharmaceutically optimized LSD, and as you say, multi-hour experience after taking it, and then lasting change. What's really neat is, again, as you said, people have experiences potentially while they're on drug that can be extraordinarily deep and meaningful and memorable, and again, memorable in some cases for the rest of someone's life, and maybe described as the most important experience of their life. And I think it's really a nice idea that they work at least partially by that mechanism. There's a debate in the space that, between, I think, a false dichotomy between they work via some psychological effect and they work via some sort of neurobiological sequelae of what the drug does on the receptor level. I think the answer is probably both, and different in different people, but they are, LSD specifically, very, very potent. All of the class is able to result in strong perceptual and mood and affective changes. So we're talking about drugs that are drugs still, but do seem and do have these very, very profound acute changes associated with them. The hope, of course, and I think as more and more research is done, as our research comes out, as others does, and as we look at retreatment over time and disease trajectory over time, the hope, of course, is that these drugs are more like, say, dynamic psychotherapy, in that they create lasting change in how it is to be the person who's been treated. And we're always hesitant to talk about cure or disease modification. Is a little strange when it comes to psychiatry, but lasting change really is the highest hope for any psychiatric intervention. And these drugs, more than any other I've seen, offer promise in that direction.
And so can we talk about, some of the specific work and the trials that you're doing at MindMed? Give everyone a basic overview of what MindMed is and sort of where it comes from. And maybe let's just start with the one that you mentioned, the MM120 drug.
Yeah, so MM120 is a pharmaceutically optimized form of LSD. It's been MindMed's leading drug for as long as I've been with MindMed, for almost 2.5 years now. We are currently conducting a sponsored regulatory grade phase 2 trial with MM120. And the point of this study is to look at different doses. So we have 4 different dose arms: 25 micrograms, 50 micrograms, 100 micrograms, and 200 micrograms, and then placebo arm as well. And it's a single administration. Now, interestingly, now that you've heard me go on and on about psychotherapy, in our drug studies, we've really de-emphasized psychotherapy to the point that we don't have psychotherapy happening in our studies. You hear ideas like preparation, integration thrown around. I think they mean so many different things to different people that they're almost not meaningful terms anymore. So if we call preparation something that happens before someone takes a psychedelic drug, well, we have an informed consent process as someone joins the research study. And that process includes things someone might experience while they're on drug or not on drug, of course, because some folks are either getting a low dose or a placebo. It includes what the folks in the room, who we call dosing session monitors, there are 2 in every session, might do if someone's having a tough time or has an anxious reaction, or if they need to go to the bathroom and don't feel super comfortable getting there on their own, or they want a snack. And then we have assessments after the session. And what we're looking at as our primary outcome measure is the Hamilton Anxiety Score, which is the standard regulatory grade FDA-facing instrument for assessing anxiety. And we're looking at that at primarily 4 weeks, and then also following out to 8 and 12 weeks to see about sustained change. And we're doing some tests earlier on as well to look at the rapidity of the change and how quickly people experience that change.
And you said it's a clinically optimized version of LSD. So what does that mean? What was optimized about it? How does it differ from regular LSD, whatever exactly that means? And why did it need to be optimized in some way?
Yeah, so LSD is tricky to make, and it potentially historically has been unstable and doesn't have good shelf stability, and obviously LSD manufactured in illicit labs is of unknown quality, and who knows what else can end up in there. But this is so regulatory grade, manufactured via good manufacturing processes with very good stability, delivered in a medically recognizable way. Some of what we're doing in the development of LSD as MM120 is still undisclosed, but certainly as we work along the way and as more IP gets published and things like this, there'll be more to say about how exactly we're going to deliver a to be marketed product.
So okay, so one of the ways it was optimized is that we know LSD is sort of a very it's sort of a complicated chemical, and it's very delicate, right? So it's light sensitive, it's heat sensitive. For those who don't know, it's actually very sensitive. You took a vial of LSD and put it in indirect sunlight or something, it would basically be destroyed in I don't know, an hour or 2, or certainly an afternoon. Okay, so it's a more stable version. And can you just talk a little bit? We don't need to go into a lot of detail, but maybe you can't yet. But like, how is it stabilized, or what does LSD D-tartrate mean chemically?
So it's a salt with the D-tartrate, which is not always what LSD salt is made with, but both the manufacturing process, the conditions under which it is introduced into the capsule formulation that we're using in the phase 2B, storage conditions, all of these sorts of things address exactly what you're saying, that we want to make sure that the drug we're delivering to participants at the study site, at the time of their dosing, is what we claim it to be. It's the right quantity of the active drug, and not degraded in any way at the time of administration. And as I say, they'll obviously over time they'll be able to say more and more about how we're thinking about a to be marketed product.
And so remind us, so what the clinical trials that are underway or that will soon be underway, what ailments are you looking at? And like, why did you choose LSD as opposed to psilocybin or something else? And why did you choose these ailments?
Yeah, so generalized anxiety disorder is the target of our phase 2b 5-arm study, the dose range finding study. And as I said before, GAD, historically a very relevant disease, the primary focus of psychiatry for a long time, really until the SRI era, was anxiety disorders. And it was only through the promotion and sort of mainstream and widespread adoption of SRIs that MDD became this primary diagnosis. And of course, as any diagnosis gains a population behind it, gains epidemiological relevance because it's being diagnosed more money flows into it. And that's a sort of a forward feedback loop that's led to just a ton more focus on MDD over the last 30 years or so. But we think GAD is an incredibly valid and relevant diagnosis. The pendulum does seem to be swinging back to a more moderate or modulated direction on thinking about depression versus anxiety and how they fit together and sometimes don't fit together. There's recent USPSTF, so that the Preventive Services Task Force for the United States, that makes screening recommendations based on disease burden and cost effectiveness and things like this, has now recommended over the past year and a half that all adolescents and children, I think 8 years of age and older, get screened for anxiety disorders, that all adults be screened for anxiety disorders. So growing recognition of the importance of anxiety, it seemed like a good white space for us, with most of the other companies in our sort of field or adjacent to us going either in the MDD or PTSD direction. It seemed like a good place for us to go. Why LSD is a really good question. I mean, one, nobody else is really doing it. Certainly not close to where we are in progressing it, whereas there are a lot of psilocybin companies. There are several companies looking at shorter acting psychedelics. The idea that MM120 might have more horsepower to create lasting change than other drugs, right? It's known to have a slightly longer duration of the acute experience. Well, maybe that translates into more durable or more pronounced, more stronger impact on symptomology. So a combination of being able to go to some place that most other folks weren't going in both diagnosis and drug, and a very real, historically, before the Prohibition era and psychedelics, LSD was by far the most studied of them all. The thousands and 10,000 plus patients in some form of clinical study or another. Good efficacy demonstrated against a range of affective and substance use disorders, anxiety disorders. So, you look back historically, LSD was what folks picked to work with. And then you move to now, and the focus really not being on it, it presented a great opportunity to take a drug that had generated so much historical excitement and to bring it back into the sort of mainstream drug development processes.
Yeah, and I'm really sort of intrigued and pleased that you guys are not only, you're doing other things as well. You're using a hallucinogenic drug. You're actually using, what's probably one of the, if not the longest lasting one. And you're doing that even though it's inconvenient in many ways. The natural incentive for a lot of people doing this type of work is, right, people naturally want shorter acting drugs because then you don't have to have a 6 or an 8 or 10 hour session with someone. Right? There's a lot of emphasis, and I'm sure you guys are also probably working on these types of things to find non-hallucinogenic derivatives of psychedelics, because that would also be convenient. So if you think about the structure and the incentives of the healthcare biopharma industrial complex, or whatever you want to call it, right, the ideal drug is going to be one that's short acting, that's non-hallucinogenic, et cetera, et cetera, et cetera. And to the extent those can be discovered, great. But as you said, I think something's very important here. The fact that the experience lasts so long is to do with the fact that LSD, sits into its receptors for a very long time. And there's good reason to think that might actually potentiate some of its beneficial effects. So I think it's good that you guys are pursuing this type of drug.
Yeah, your point is well taken. It's a very, very potent very, very potent drug given in, microgram, tens, hundreds of microgram level, not milligrams, and does sit on the receptor in a different way than maybe other drugs, and can obviously have a bit of a longer acute duration and dose dependent to some extent. The idea that shorter acting drugs better fit into the existing paradigm for care. Okay. Yeah. That's probably true. And does the existing paradigm for care, is that some inviolable thing that has to continue to exist forever? Well, no, it's an emergent property of a system that had certain treatments available and incentive structures set up. So, what we're confident in is that if we can show strong, rapid, durable effects, that the system will accommodate getting that to people who need it. And we're awfully focused on things like health economics and outcomes research to really, starting even now in the phase 2, to look at longitudinal utilization and be sure that we're actually able to induce lasting change in how someone accesses and needs healthcare services, because ultimately those data will be the ones, and we bring efficacy and safety data to the regulators for drug approval. But boy, if we just get drug approval and folks in need can't get drug because we haven't done the groundwork to show economic benefits to payers, then we haven't really done our job. This has to be accessible to folks who can't just pay, can't pay out of pocket in order for us to have been successful, both as a company financially, but I think as drug developers who actually want to see change in the world. So there's sort of been both an ethical and financial incentive to make sure that we're really delivering something to people suffering that they can get access to. Yeah.
And, thinking about LSD itself, I don't know if you've completed any of these trials with LSD or you have results to report there in terms of the trials you guys are doing. But what's known about LSD, both from human and animal research, in terms of how it's working and why it might be a good candidate for something like anxiety disorders?
Yeah, well, we've hit a couple of these points already. In the historical, we point to the historical research, mostly academic historical research, as more hypothesis generating than hypothesis answering, and that's true even of academic studies that are done today. But again, like I said, 10,000 plus patients dosed in various clinical studies in the pre-prohibition era, and remarkable efficacy against a whole wide range of conditions, dosed at lots of different dose ranges. I mean, people talk, and again, this goes back to the very beginning of our conversation about what we know versus what we sort of claim or think we might know. And so people talk a lot about set and setting as a sort of a set of concepts around psychedelic administration. But there's a historical LSD study where people given, I think, 800 micrograms. So our highest dose in our multi-arm study is 200 micrograms.
Yeah. And let's remind people, what would a standard recreational dose be? Something like 100 to 150 micrograms?
I think, 100 to 200, 100 is considered, and again, this is, anecdotal, and who knows, to some extent, you don't really know what people are getting in terms of precise dosage ranges from an illicit supply of drug. But sure, 100 is certainly a perception altering dose, and 200 ought to be pretty profoundly perception altering. I mean, and 100 can be too. So 800 a whole lot. This was an experiment, again, and now we're talking in the 50s, done with folks with what we would today call alcohol use disorder and then alcoholism, where folks were given 800 micrograms and just strapped to a gurney in an ER and left to ride it out. And it showed good efficacy in those studies too. So it's, again, there's so much here that we don't know and that hasn't been investigated in a rigorous modern way. And it's one of the reasons our phase 2 is set up the way it is, particularly things like multiple dose arms and taking psychotherapy out of the equation. So we know we're just testing, to the extent possible, isolated drug effect, not a complex interaction between drug and a psychotherapeutic process. A lot of what even if you look at, we have another MM120 study where we're looking at 20 micrograms every third day at a couple of sites in Europe against ADHD. And the hope there is to investigate in a rigorous, sponsored way. Does sub-perceptible or perceptual threshold dosing create change? and there's a lot of anecdotal reports one way or the other. There's some not.
You're talking about microdosing.
Yeah, you notice I kind of consciously didn't say microdosing. This is another, and we try to sometimes stay away from some of this language because it carries a lot of implications, right?
Mm-hmm.
So there's a drug like quetiapine or Seroquel can be dosed anywhere from about 20 milligrams up to about 3 grams a day is the use. It doesn't know what it's labeled for, but that's higher than labeled. So if you think about the difference between even 20 micrograms and 2 grams, that's bigger by a lot than the difference between 20 micrograms and 200 micrograms, right?
Mm-hmm.
So we're talking about a 10x difference. So nobody talks about microdosing Seroquel. And so we're very much, it's almost
sub-perception altering.
Right?
Yeah.
Or and so we say sub-perceptual, but what we mean in this case is, we know it doesn't create hardcore perceptual
hallucinations.
Yeah, it would cause someone to be unable to function normally in their daily life. But if you have ADHD and now you're better able to do the tasks of your daily life, that's a perceptual change too. Right. It's just not the same as you'd get if you took 10 times the dose or like that at all. So just doing the legwork to figure out, does this low dose, this sub sort of perceptual dose, do something that enables folks to be able to function better? And that's another study that we'll expect to read out. So the phase 2 for GAD, we expect to read out by the end of the year. The ADHD study, which is a smaller study, but very much sort of proof of concept study, we expect to read out by the end of the year as well, asking 2 fundamentally different questions about MM120 and LSD, but both of which fill gaps in our modern knowledge base about the drug.
I see. So we should expect to hear the results of some of these later this year.
Yeah, that's what we've been guiding, is that we'll have top line readout from both of these studies by the end of this year. Yeah.
I see. And what does top line readout exactly mean? Like a paper is published, or does that mean the results are shared publicly?
That would be the publication process takes a while, but we would announce primary readouts from the unblinded data. Right? There's a whole process once you finish running people through whatever outcome measure you're going to run through. Then unblinded analysis of the data, of course, because to date we of course have stayed blinded to the treatment allocation, so we don't have any, and in fact, no one has been looking at the data from an unblinded perspective. So that's what happens as you go to the sort of analysis and readout phase of the study.
Another drug that's very interesting that people are very excited about is MDMA. Obviously, MAPS, the Multidisciplinary Association for Psychedelic Studies, they've been doing the very large phase 3 clinical trials for PTSD, and they've gotten really striking, really promising results there. And you guys, I think, are using it for autism spectrum disorders, which I think is very, very interesting. So for those who don't know, maybe give a little bit of background on why MDMA would be a good candidate for that particular disorder, and just talk a little bit about what you're doing there.
Absolutely. And I'm glad you raised MAPS, because one of the important things to point out just from the get-go, there are 2 critical differences between how MAPS PTSD study with MDMA is being conducted and what their study procedures are, and of course what their commercial target will be, and our MDMA programs, where MM402 is the right enantiomer of MDMA. So MAPS is using racemic MDMA, so it has a right and left enantiomer. And folks, I'm sure listening, will either remember or not remember from high school chemistry that molecules can have chiral centers, which means that fundamentally they become non-superimposable mirror images. So think your hands, right, that they are non-superimposable and they are mirror images for the most part. The other difference, so we're just using the right enantiomer, and I'll talk in a minute about why we picked the right enantiomer. The other difference is that MAPS is using racemic MDMA as a psychotherapy enabler or enhancer, which historically it had been used as before it was made Schedule 1. And fundamentally what that does, and having talked to folks who've been involved in the current study, and historically I was trained by some people who had used racemic MDMA in the pre-ban era, and it builds a sense of rapport and a sense of trust and connection between therapist and patient. And for a lot of psychotherapeutic processes, they depend on that openness and trust and willingness to share. And even things like in the psychotherapeutic encounter, transference feelings, right? I'm now feeling something about you, but saying that can be really hard in psychotherapy, right? What you need to experience the transference and communicate it to the psychotherapist so you can interact with the transference together. And so things like that are enabled by the dose of MDMA that is being used in those PTSD studies. Those studies use a form of psychotherapy that maps to sort of train folks in and all of this. So right enantiomer, let's start there. So it looks like the left and right enantiomer is based on animal data, some limited human data. The left enantiomer seems very much to drive the amphetamine-like effects of MDMA.
So the stimulant.
The stimulant qualities. So in animals, that can be measured by increased locomotor activity. They walk around more, they're moving around more. In higher doses, it seems to drive the hyperthermia that can be associated with higher doses of MDMA. The right enantiomer, and this is we call it the stereospecific pharmacodynamics, right? That the receptor action, you'd think two molecules that are very fundamentally non-superimposable mirror images of one another would have relatively, sort of intuitively say, well, shouldn't they do the same thing? But often in neurobiology, we find that in fact there is a lot of stereospecificity, and the right enantiomer seems to drive in these animal studies, including an animal study that we recently conducted looking at a Fragile X model of autism in mice, seems to drive a lot of the pro-social activity of MDMA.
So in other words, people have done experiments where they give mice just the R version and just the S version, and they see differences in the amount of pro-social behavior change with two.
That's exactly right. And differences in the amount of locomotor activity, so that you see that the left drives like walking around, moving about, and the right drives the social behaviors.
I see. So that makes sense of why you chose this enantiomer, the R MDMA, to do the autism study with.
Yeah. And so then the other key difference is we are thinking of MM402 as a repeat daily drug for folks with autism spectrum disorder. And what we know, FDA did a patient-centered drug design workshop with folks with ASD and caregivers and other stakeholders in the communities. And social communication, social connection, social relatedness all float to the top as things that both caregivers and of course people with autism spectrum disorder want help with. And in the current, and there are psychotherapeutic interventions that can help there. There are occupational therapy interventions that can be helpful there. But fundamentally, from a drug perspective, the drugs approved for ASD to date are really oriented around behavioral discontrol. So things like second generation antipsychotics that for someone who has ASD and has difficulty with behavioral discontrol, a drug like a second generation antipsychotic, which is sedating and has some other receptor effects that might help with behavioral discontrol, but it's not fundamentally an enabling drug. It's really about suppression. And the hope is that RMDMA as a daily drug for folks with ASD can be an enabling drug, that it can enable folks to engage in educational, vocational activities of daily living that involve social interaction and be better able to perceive social intent from others, to engage in social activity with others, to possibly perceive their own internal state better.
Yeah. And what's interesting about that too is sort of the acute effects of increasing pro-social behavior, the ability to just go interact with people in a good way. To the extent that does happen, that would actually sort of unlock downstream benefit, because then those social interactions themselves will have neuroplastic effects and lead to learning and plasticity all on their own.
You sure hope so. I mean, the analogy that I often use for this development paradigm is psychostimulants for ADHD. And we've had those for quite some time now. They're certainly, this is not a totally clean, like this is great for everybody and we should have them. And I'm not advocating for psychostimulants. They're very appropriate in some cases. But when we give folks with ADHD psychostimulants, they're better able to engage in their lives. and to pay attention and to be less hyperactive in school and things like this. And whether that leads to lasting neurobiological changes or not, I don't have a dog in that fight. But the idea that by being able to better participate along the way, that people's life trajectory changes, we very much have seen evidence of that. And so it would be absolutely awesome if our MDMA treated folks then were better able to have these same social experiences off drug over time. If it were disease modifying, that would be awesome. I don't have evidence one way or the other. Of course, we'll look for that as we develop the drug further, but at the very least, trajectory change. So if you think about someone who's engaging in school and better able to communicate and make friends in school, well, that's going to change the experience of being in school and make it a more pleasant, more desirable experience. It'll change the ability to learn from peers. And so whether there's lasting neurobiological change, which again, I just can't tell you. There's very much I'm very hopeful that life trajectory change is possible just by being able to be more functional in one's life.
And I can't remember if you mentioned it. Can you remind us the doses that you're using for this study? And then after that, maybe talk about how you guys think about things like whether or not there's any risk to chronic administration of MDMA, especially in the context of the sort of colorful history in MDMA research around neurotoxicity and dose and different views on that.
Yeah. So we haven't talked about dose yet because what we're doing first is, of course, phase 1. Our MDMA has not been in clinical trials before, certainly not sponsored clinical trials. So the first step is phase 1, where we look at dose, tolerated dose, and we'll do regular, it's called SAD and MAD, so single ascending dose and multiple ascending dose study to look at both low dose effect, because we can start to look at, this is a neat thing about prosocial effects, we can look at it in healthy folks too, unaffected folks. So we'll start at relatively low doses and dose up to look at side effect profile and dose limiting. Of course, if we get to dose limiting side effects, stop. And then in the MAD, do something similar, just look at day by day dosing. And then the hope is and so that study, the phase 1, will start by the end of the year as well. And then we'd like to have a cohort of folks with ASD as a third cohort, as a third part of that study, to look for what we would call ESOE, or early signs of efficacy, to sort of gain internal confidence that we're headed in the right direction, that this drug at a dose that's tolerated and safe creates the effects we're looking for in terms of the ability to interact socially. So that's where we're at in that development program.
And so what kind of doses are you using, and how would those compare to, say, what we think a standard recreational dose is?
Lower. So I mean, we'll start lower. The point of the phase 1 is also to get to what dose we'd like to use to test efficacy. So where we'll end up with the actual dose that we bring in to look at efficacy, I can't tell you, because that's part of the experiment where we're going to be doing.
But are we talking like 1s or 10s of milligrams?
10s plus. Yeah. And part of phase 1 is getting safety coverage above where you think you'll need to go, right? And so that those doses can be pushed reasonably high. Of course, we're monitoring carefully to be sure that we're not exposing anyone to risk. And this relates to the second part of your question that I didn't answer before, which is, how do we think of toxicity? And a lot of this sort of breathless 80s coverage of, MDMA and neurotoxicity and Swiss cheese brain and all this sort of stuff is just there's not evidence for that in any really what you'd call a reliable way. And so we are doing a very standard IND enabling tox package. So, investigational new drug applications, which you file with FDA to be able to take a new drug into people. We're doing the animal tox now that's required to go into human studies, and looking at a whole range of potential toxicities. So far, we have some animal tox work that'll be published, and so far what we're finding is that we expect that we'll, again, as I said, we'll be able to open that IND and head into a phase 1. Certainly the phase 1 start by end of year is something that we've said consistently.
And so on your website, there's also like a section on digital medicine. And so what is that, and what is that all about?
Yeah, and we didn't talk about this at the beginning, which is the how I came to MindMed at all, and why you're talking to me about this stuff. I was not in the psychedelics world in any way. I had been developing drugs at Pfizer in the past, and psychiatric drugs, and Pfizer left neuroscience. And so one of the things that I worked on at Pfizer after Pfizer left neuroscience was what we call digital medicine, and the ability to use digital devices and digital tools to do better measurement. And this goes all the way back to the beginning of the conversation. We were talking about disease definitions and phenomenology and signs and symptoms. And so my thought then and subsequent to leaving Pfizer, when I founded a company called Health Mode, was how do we use digital tools to best measure the signs and symptoms of systemic illness, not just psychiatric illness, because not all, but a lot of systemic illness suffers from the same definitional problem, which is that the disease definitions are built on signs and symptoms. We don't have terribly accurate or precise ways to differentiate in a fine-grained way between signs and symptoms that might look similar or even have the same name but not be the same thing. And so when MindMed acquired Health Mode and brought me in as chief medical officer, we brought digital capacity in from Health Mode as well. And we're looking at a number of different angles that we can use that digital technology to measure things that can assist in understanding the diseases that are anxiety and affective illnesses, as well as are there things we can do at the point of care where a drug is being administered and someone is having a dosing session to help the folks monitoring the person know things about what's happening with them. And that can ultimately that will lead to some regulated, labeled digital devices called software as medical device that can assist folks who are working with people at the point of care with MM120 and potentially other drugs.
And this is kind of a hot topic. It's very general. There's multiple ways to think about this and where we could go with it. But the idea of whether or not the psychedelic effects, the hallucinogenic perceptual changes of things like LSD, psilocybin, and so forth, whether or not they are basically just side effects and they're not therapeutically relevant, or whether they are very relevant to therapeutic outcomes. How do you just start to think about that problem in general terms? I'll just leave it there.
Yeah, and a lot of people think and talk about this and again, we talked about the idea of a psychoplastogen before. I try as much as possible to go back to some basic principles. Our brains are plastic. Neuroplasticity is a thing. I mean, this is what Eric Kandel won the Nobel Prize for, right? Was that memory requires structural changes in your brain. That's a good thing for a lot of reasons, because if encoding memories didn't require changes at a structural level in your brain, where are they being stored, right? And so it's easy in psychiatry sometimes to drift into this sort of functional dualism of like something other than the brain being the mind. I think we have to sort of abandon that and accept that the brain and the mind live in the same place. And so this conversation, or even for folks listening to us have these conversations, if they remember it, we've created physical change in the brain. So that's the constant thing, right? How does that relate to healing or getting better or feeling better? Open questions, all of them. There are drugs in psychiatry that are known to be very plastogenic, like lithium is one of them. And lithium's a remarkably effective drug for bipolar disorder. It's also shown efficacy against depression. That doesn't have a label for that. So the idea that I don't think we know the answer. As I said before, I hope that the experience, I hope the psychological mechanism of the drug, it would be, I think, real like a nice thing. It would be a great thing if that mattered and that was part of the mechanism. I think that we are increasingly aware that there are downstream long-term changes that can be induced by using existing psychedelics, whether those changes are are the product of the psychological experience or the product of some downstream signaling and neurobiological process. I don't think we know yet. I understand very much the appeal to companies of going and looking for non-hallucinogenic drugs that create similar downstream changes to the existing psychedelic drugs. We will only know once those drugs get to people if they're actually psychoactive and result in as I've said about MM120, in rapid, profound, and durable change in people's psychiatric disorders. So I'd say that the jury's out there, people working hard to try to answer these questions. And the nice thing about having MM120, which is, again, has this historical efficacy data, a lot of evidence for safety, and now increasingly emerging evidence for efficacy, even from some collaborators of ours in Switzerland who've published on both efficacy against anxiety disorders and depressive disorders, academic studies, of course, but valuable nonetheless, that we get to dodge that question a little bit of psychological versus neurobiological and say, well, okay, if we can move a valid clinical outcome assessment in a strong way, rapidly and durably, then we've got a good drug to bring to market that will help people. And of course, we're very conscious of having a pipeline behind that. But currently, what we're really mainly focused on is this drug that's extraordinarily likely to show efficacy.
And, for a lot of these drugs, like you're referring to it as MM120, and this is another name for this particular LSD salt that you guys have developed. And, what ties into that is the idea that, this is going to be a particular version of LSD that is patented and owned. And so if clinical trials turn out the way we hope they do, and these drugs are brought to market, how do you think about the questions around accessibility and cost, and how does that tie in? How do you have to think about that as sort of the science person doing the clinical trials, as a business who has to keep itself going and running, and then also patient accessibility and making sure things aren't exorbitant or inaccessible to the people who actually need the treatment?
Yeah, and there are a few components of access, and that there's a drug price component, and then there are the service prices that sit around the drug. Drug pricing is something we'll have to come to, and we've hired a chief commercial officer now for quite some time, and are increasingly thinking about how to both demonstrate value and through the demonstration of value come to appropriate drug pricing, and then thinking about environments in which this drug might be prescribed and in which it might be administered. The kind of thing that I think gets lost a lot of times in these conversations is that while there's a lot about our current drug and this entire environment that feels really different, and there are things that are really different, there are a lot of things that aren't that different. And so for a psychiatrist or an advanced practice nurse to see a patient, someone with prescribing power, do an evaluation and management visit, bill their insurance for that evaluation and management visit, well, that's going to be probably done exactly the way it's done today for any prescription. The doctor will meet with someone and maybe meet with them via telehealth and do a robust assessment of their appropriateness for treatment and their safety, their ability to take the drug safely. They'll prescribe it. Likely, the drug will need to meet someone at the place where it will be administered. Could be administered in a lot of different kinds of places. There are clinics that have come into existence around interventional psychiatry, like clinics that do Spravato or esketamine as a treatment. And so they have facilities set up for monitoring and for someone to be while they're on the treatment. Individual psychotherapist offices. While for our drug studies, of course, we're using study sites. There's no reason in a commercial world that a psychotherapist who ordinarily practices a talking psychotherapy couldn't be a session monitor and monitor someone while they were under, having an experience with drug. And here's the part that I think, in a lot of the talk about billing and coding, what gets lost is that psychotherapy gets billed today, and it's a time-based code. And a lot of the Spravato in the world is getting billed as a psychotherapy hour plus a hour-long psychotherapy add-on code, because there's a 2-hour monitoring period. And if someone's getting, 6 treatments with Spravato in their first 2 weeks, or 12 hours of time in clinic, plus the back and forth and travel time, starts to make a single day of MM120 LSD treatment. It's actually less time. And if you have a durable effect that lasts out, 12 weeks, well, that's going to not be unfamiliar, right? In terms of a time commitment from the payer to compensate the provider for an effect that lasts that long. Weekly hours of psychotherapy are often covered by many payers. So while there's going to be a lot of demonstration of value that we have to do, and a lot of engagement with payers and providers to be sure that folks are ready and confident and comfortable to engage in a world where something like MM120 is available, it's not that far from where psychiatry is at times today.
Are there any other, psychoactive drugs that are in your R&D pipeline beyond the LSD and the MDMA chemicals that you're working with? And if so, what are they?
There's one other disclosed pipeline component, which is a drug that now has a lot of names. MM110, 18MC, and Zolunacant are all of its different names. It's a non-hallucinogenic derivative of Ibogaine. Ibogaine being a hallucinogenic compound that has been used to treat addiction and is used in the underground and outside of this country for addictive disorders. It does cause pretty profound hallucinosis for folks. And Ibogaine has an unfortunate cardiotoxic potential where some people have what's called prolonged QT and suffer from a heart dysrhythmia from Ibogaine. So 18MC or Zolunacant or MM110, I never know which name to use, doesn't have the cardiac liability. It doesn't have the hallucinogenic potential. We brought it through. This drug was in the pipeline when I joined the company. It was in a phase 1. We brought it through the phase 1, got to dose coverage and exposure coverage that we believe is likely to correspond to the animal data that suggested efficacy. There's some more animal tox work to be done to be able to bring this into an efficacy study. So right now, because of the capital markets and really needing to focus our resources on 120 and 402, Zolunacant's 18MC has been in a bit of the backseat for the last bit here, but we're seeking non-dilutive funding, grant funding to try to do the additional work we would need to do to go into an ESOE efficacy study in opioid withdrawal.
And can you give us a sense for like how long some of this stuff takes? So like let's say the phase 2 trials for LSD, start to finish, from sort of inception and really sort of hitting the ground, starting those trials, to when you think like the first, results will really come out and be announced. How much time are we talking about there? Is it a year or two? Is it longer than that?
A year or two is reasonable for, we consider ourselves to be as efficient as anyone in the space, and to be, we've got a really fantastic drug development team who are incredibly competent and capable at running these studies. In our studies, we are very close to the sites, so this is not the kind of thing where we hand it to a contract research organization and say go run our study. Of course, we have a CRO involved for certain functions, but our ClinOps and clinical team are in almost constant communication with our sites. I personally have visited a number of the sites. Rob Barrow, our CEO, has been at a number of the sites. So we try to have very, we want everyone to be aligned. We want these studies run with as high fidelity, as much of a focus on safety and adherence to protocol requirements as possible. So, But yeah, a year or two for the phase 2. What we've said is, and what we'll continue to say is, read out by the end of this year. Sometimes these study startups can be a little more complicated than more like sort of regular drug development startups, where you don't have to have Schedule 1 licenses at the sites and things like that. Of course, we're still handling a Schedule 1 drug. Lots of lessons learned through the conduct of our phase 2 that we'll bring into the phase 3. and we're going to just turn that over as quickly as we can into, from the end, you finish the phase 2, get the data back, have an end of phase 2 meeting with FDA where you ask questions and propose a phase 3 plan and transition that into as rapid a study start as we can. And of course, have pre-existing relationships with sites who've got phase 1 licenses or have Schedule 1 licenses at this point. So we're eager to just keep cranking along and to get to the phase 3 and get to obviously submittable phase 3 data as quickly as we're able.
And can you tell folks just a little bit more about MindMed? How long has this company been around? Sort of, when and why was it started? And I don't know, maybe talk a little bit about like, what's your sort of strategic vision that informs like how and why you're making choices around, which drugs to test and which drugs to look into?
Yeah, absolutely. So MindMed was founded more than 3.5 years ago. So by folks who I think saw, that none of these original founders are still involved with the company, but saw the opportunity, saw what was happening in the space.
If you're hearing this, you are listening to the free version of the Mind and Matter podcast. The first part of episodes are freely available to all listeners, and the full episode is available to paid subscribers at mindandmatter.substack.com. Paid subscriptions help sustain the podcast and increase the quantity and quality of the content I produce. However, I don't want anyone to miss out on learning from my guests just because they can't afford a subscription. If you're interested in hearing full premium episodes but can't afford a paid subscription, simply sign up for my free weekly newsletter, send me an email, and I will give you a free paid membership, no questions asked. Paid subscribers enjoy benefits like ad-free episodes, early access, and other subscriber-only content on the Mind and Matter Substack. As always, I thank you for your support. No matter how you engage with Mind and Matter, the simplest and most effective way to provide support is to share your favorite episodes with family and friends. Hey everyone, I want to take a minute to tell you about a really cool health monitoring device I've been using for several weeks. It's called Lumen, and it's a handheld, pocket-sized device with a sleek design. It measures CO2 levels in your breath, which allows their technology to determine the extent to which your body is burning fats versus carbohydrates. Lumen helps improve your metabolic flexibility, your body's efficiency in shifting between using fats and carbs. It improves your ability to burn fat, which decreases your hunger levels and makes your body less dependent on snacking, and it can increase your energy levels by helping you develop a high-functioning metabolism. I use this device in the morning, before bed, and after meals and workouts to track my metabolism. With just a couple weeks of use, I learned a lot about which foods were causing my body to burn mostly fat, mostly carbs, or both, as well as how long I need to fast each day to promote fat burning. Lumen is great for anyone looking to optimize their health for either weight loss or athletic performance. The easy-to-use app allows you to track your results together with what you're eating and how you're exercising, and it syncs with other devices like the Apple Watch. Click the link in the episode description to learn more and use the code MIND, M-I-N-D, in all capital letters to get $50 off your Lumen device today.